So today we are starting a new chapter, that is the endometriosis and the adenomyosis, in which the first topic is endometriosis. Endometriosis is simply defined as the presence of the endometrial tissues outside the uterine cavity. So in endometriosis, the endometrial tissue is present outside the uterus, and the endometrial tissue is structurally and functionally similar to the uterine endometrium. And the endometriosis occurs in about 10 to 15% of women of reproductive age, and it is an estrogen dependent condition, and the exact cause of endometriosis is unknown, and the etiology is explained by various theories, in which the first and most acceptable theory is Samson implantation theory. In this theory, there is retrograde menstruation occur and implantation of the endometrial tissue outside the uterus. So the Samson theory suggests that there will be retrograde menstruation and implantation of endometrial tissue outside the uterine cavity. Retrograde means that during menstruation, some blood and the endometrial tissues, they flow back via the fallopian tube into the pelvic peritoneum. Second one is the Mayer-Silomic metaplastic theory. According to this theory, the coelomic epithelium, which are the parietal cells that line the Mullerian tract, that transform into the endometrial cell. So the coelomic epithelium transform into the endometrial cell, and this transformation can be triggered by the hormonal stimuli or inflammatory irritation. Third one is the vascular and lymphatic spread theory, which is also known as Heilbron's theory. According to this theory, there is spread of the endometrial tissues to the other side via the lymphatic system or the vascular system. And the fourth one, which is a less common acceptable theory, is the genetic and impaired immunity therapy. According to this theory, there may be genetic and immunological factors which contribute and the susceptibility of women having endometriosis. And according to this theory, there may be a defective immune system which causes impairment of the clearance of the ectopic endometrial tissue. So there will be defective clearance of the endometrial tissue and will lead to the endometriosis at an abnormal site. Next one is the symptoms of the endometriosis. So the first and most common symptom is cyclical pelvic pain, and this pelvic pain is cyclical in nature, and it is the most classic symptom of endometriosis. And pelvic pain occurs at the time of menstruation. That is why it is also known as the cyclical pelvic pain, and it is non-colicky in nature. And the patient may also complain of lower back pain, and there is deep dyspnea occur. Dyspnea means painful intercourse, and dyspnea suggests that there is a implantation of endometrial tissue within the pouch of Douglas, and there is also dyschezia, which means there is painful defecation. It also suggests implantation of the endometrial tissue at the pouch of Douglas. The other sites where the endometrial tissue deposit, they include nasal deposit, which causes cyclical epistaxis, which coincide with the menstruation. There may be rectal deposit, which causes rectal bleeding along with menstruation. And if the endometrial tissue they deposit in the urinary tract, they cause a cyclical hematuria. And the endometriosis also causes infertility, and the causes of infertility include inovulation. There may be lysis of the corpus luteum occur. There may be reduction in the tubal patency due to endometriosis. There may be reduced in the intercourse frequency occur, anti-sperm antibody, and there may be early pregnancy failure occur. And the early pregnancy failure may occur because of prostaglandin induced factors and the immune mediated factors, and all of these factors can lead to the infertility in endometriosis patient. The common site for the endometriosis are pouch of Douglas, posterior broad ligament, uterosacral ligament, fallopian tube, sigmoid colon, appendix, and the ovaries. And the ovaries are the most common site of the implantation of the endometrial tissue or the endometriosis. And the ovarian endometriosis is also known as endometriomas. They are also known as the chocolate cyst, because these cysts contain blood which is red or brownish in color. So the ovarian endometriosis is also known as endometriomas or chocolate cyst. The other common site for endometriosis are lungs, brain, muscle, eyes, and these side there may be a rare deposition of the endometrial tissue occur. Next one is the diagnosis of endometriosis. So first we will take a detailed history in which we ask about the age of the woman, any history of the pelvic pain, dyspareunia, dyschezia, and the cyclical bleeding from other side. Next, we will do by manual pelvic examination, in which there will be thickening and nodularity of the uterosacral ligament, tenderness in the pouch of Douglas. If there is deposition of endometrial tissue in the pouch of Douglas, there is pecs with overted uterus. There may be rectovaginal nodule, and there may be palpable ovarian mass. And in the investigation, we do transvaginal ultrasound. So a transvaginal ultrasound is the best initial test, and it may detect the ovarian endometrioma, which shows the ground glass appearance. Similarly, we also do the MRI, which tell us about a deep infiltrating lesion, and it will tell us about the exact site of the endometriomas and the extent of endometriomas. Similarly, we also do laparoscopy, which is an invasive technique, but it is the gold standard for the diagnosis of the endometriomas, because laparoscopy allow us the direct visualization of the endometrial tissue at abnormal site, and similarly we can also take biopsy from the tissue. And the endometrial tissue usually appear as a powder burn and blue black spot. Similarly, in endometriosis there may be a base in the level of CA125 tumor marker, but it is not diagnostic, and it is only done for follow-up. Next is the treatment or the management of the endometriosis. So first one is the medical treatment. The goal of medical treatment is to reduce the cyclical pain that occur due to menstruation, and any regime that stops the menstruation and induces pseudomenopause will help with endometriosis with related pain. So the drugs which are used in the medical treatment of endometriosis are NSAIDs, COCPs, progestogens, GNRH agonists, and the danazole. First one is the NSAID. So NSAIDs are used for dysmenorrhea and pelvic pain, and they are used for the symptom control, and it has no effect on the disease and its progression. Second one is combined oral contraceptive pills. So combined oral contraceptive pills, they cause amenorrhea. They also provide contraception, and they are helpful for treatment of dysmenorrhea and dyspareunia, and similarly they also improve the non-cyclical pain. Third one is the progestogen. So progestogen are used in women who cannot take the combined oral contraceptive pills, and the progestogens include depart pump, which is the medroxyprogesterone acetate, and the levonorgestrel intrauterine device. Fourth one is the GNRH analogs. So GNRH analog causes hypogonadotropic hypogonadism and induces the pseudomenopause state, and they can be given daily as a intranasal spray or in the depart pump, and they are associated with increasing risk of osteoporosis, heart flashes, and depression, and they are not used longer than 6 months due to its side effects. And the GNRH analogs include leuprolide and goserelin. Next one is the danazole. The danazole causes ovarian suppression and is suitable to use for 3 to 6 months, because danazole is associated with increasing risk of ovarian carcinoma, hirsutism, voice change, and the weight gain. So it is no longer commonly used due to the above complication. Second one is the surgical management of the endometriosis. So the endometriosis include conservative surgical management and the definitive treatment. The conservative surgical treatment is also known as the fertility preserving treatment that is offered to the younger patient whose family is not complete. And conservative methods include destruction of the endometrial implants, lysis of the ovarian adhesions, and drainage of any collection. And the conservative treatment options include laparoscopic coagulation and ablation. And for endometriomas, we do laparoscopic drainage, and we can also do laparoscopic cystectomy. In cystectomy, there will be less chances of the spillage of the content and potential endometrial deposit, and hence laparoscopic cystectomy is preferred, because there will be complete removal and less chances of the spillage of the endometrial tissue. And for the treatment of dysmenorrhea, we can do pre-sacral neurectomy that involve the transection of nerve fiber at the level of third sacral vertebrae, and similarly we can also do laparoscopic uterine nerve ablation that causes the interruption of the pain fiber and is helpful when combined with the laparoscopic ablation of the endometrial deposit. And second surgical treatment, which is the definitive treatment, it is upper to the relatively older patient whose family is complete, and it involves hysterectomy along with bilateral salpingo-oophorectomy and the removal of all the visible endometrial deposit. Similarly, the HRT use should be avoided for 6 months because HRT include estrogen and may causes the reactivation of the any residual endometrial tissues. And the differential diagnosis of the endometriosis are chronic pelvic inflammatory diseases. There may be myomas occur, there may be hemorrhagic rupture of corpus luteum or malignant diseases of the ovary, and there may be rectal carcinoma and the ectopic pregnancy. So all of these are the differential diagnosis of the endometriosis. So it was all about the endometriosis and its management. Second topic in this chapter is adenomyosis. Adenomyosis means the presence of the endometrial tissue or the endometrial glands within the myometrium. So the adenomyosis are also known as internal endometriosis, and it involves the presence of endometrial glands deep within the myometrial layer. And the adenomyosis is more common in multi-pairs women in late 30s and early 40s. And the pathogenesis of adenomyosis include there is presence of the ectopic endometrium within the myometrium, and the ectopic endometrium within the myometrium is responsive to the cyclical hormonal changes and will result in bleeding within the myometrium. And the adenomyosis include either diffuse involvement, in which there is diffuse pattern of the endometrium within the myometrium, and there may be focal involvement, in which there is presence of focal tissue which present as a mass known as adenomyoma within the myometrium. So the endometriosis either shows diffuse involvement or there may be focal involvement of the myometrium. And the symptoms of adenomyosis include the patient may be asymptomatic, but there is severe secondary dysmenorrhea throughout the cycle, which is the most common symptom of adenomyosis. There may be heavy menstrual bleeding occur, and there may be dyspareunia, which means painful intercourse. Second one is the diagnosis. So for the diagnosis of the adenomyosis, initially we take a detailed history, we do examination, and we also do ultrasound. The ultrasound is the best initial test, but MRI is the investigation of choice, and the MRI indicate enlarged globular uterus without well defined mass, and there is a L defined endometrial myometrial interface occur in case of adenomyosis. And we also take biopsy and we do histopathological study, which is the only definitive test for the detection of adenomyosis. And an examination, we can differentiate the fibroid from adenomyosis, because the adenomyosis they causes symmetrical uterine enlargement, whereas the fibroid causes asymmetrical enlargement of the uterus. Similarly, adenomyosis is soft while the fibroids are firm, and adenomyosis is tender while fibroids are non-tender. So the adenomyosis causes symmetrical enlargement of the uterus, they are soft and they are tender. Last one is the treatment of the adenomyosis. So the goal of the treatment in adenomyosis is to induce amenorrhea and avoid the endometrial bleeding. So the agents that are used for the control of the bleeding are GnRH analogs that induces pseudomenopause and hence inhibit the menstruation, and they include goserelin and leuprolide. The second one is the long-acting reversible contraceptives that include the levonorgestrel intrauterine system and the Depo-Provera. So we stop the treatment or the cessation of treatment in case of adenomyosis. There will be a recurrence of the symptom occur, and the definitive treatment for adenomyosis is hysterectomy, which is usually upper to those patients who are not responding to the medical treatment. Their recurrent symptoms occur in relatively older couple where the family is complete. And the adenomyosis, there is diffuse involvement of the myometrium occur, and the endometrial tissues infiltrate into the myometrium, and there is L-defined endometrial myometrial interface. So it was all about the adenomyosis and its management.